Hi there. My name is Dr. Bob Motley. I'm a professor of family and community medicine at Thomas Jefferson University in Philadelphia, and also a member of the St. John Newman Catholic Medical Association Guild in Philadelphia. Today, I'm going to speak with you about healing-centered engagement of patients, approaching patients with compassion using the corporal and spiritual works of mercy. In the next few minutes, I'm hoping that we can examine the dimensions of the human person to help inform a holistic approach to patient care. I'd also like to share 4 frameworks that I have found helpful in providing insight into the lives of some of the patients we encounter. And ultimately, I'd like you to come away from this with an aspiration to be like Christ in your patient encounters, rooting them in compassion, which you understand to mean to suffer with, and the corporal and spiritual works of mercy. I'm going to give you a real life example of a fictional patient whose name is Lydia, and she's a 34-year-old patient, and she's like many who have come to see me over the years, who comes in with a complaint of a daily headache, muscle aches, and fatigue. While interviewing her, she shares the following about herself. Her headaches started when she was 12. Her muscle aches after her second pregnancy, and they bother her in the neck, shoulders, and lower back. She works full-time at a supermarket. Lydia is divorced and the mother of 2 children, ages 18 and 16. Her elder daughter is struggling with depression, which has affected her school attendance and has been disruptive to mom's work schedule. Lydia came from a family where she had 4 siblings, 2 brothers and 2 sisters. She has 2 older brothers and 2 younger sisters. Sadly, her parents split when she was 10 years old. Her youngest sister was 5 at the time. She reported that her father drank after work every day. He was sometimes abusive to Lydia's mother. She said we needed to be careful around him, depending on what mood he was in. So I want you to understand that as human creatures, we're endowed with multiple dimensions of who we are. We have feelings. We also have a physiology, which we spend a lot of time studying. We have a social dimension. We also have a conceptual or sense-making component. It's how we think and make sense of the world to integrate our experience. And we also have a spiritual dimension. And we know that our feelings can drive how we think about things and also the decisions and how we act. As well, our thoughts can also stir up feelings and can influence our behaviors. So I'd like to spend a little time talking about the following frameworks. They're listed here: Maslow's hierarchy of needs, adverse childhood experiences, a study done in 2012, which actually shows the impact of a number of traumatic experiences among children on their future outcomes. The readiness for change model, which is how we get ready to implement change in our lives, and the workload capacity model. Sir William Osler, a very famous physician at the turn of the 20th century, said it's much more important to know what sort of a patient has a disease than what sort of disease a patient has. So with regard to Maslow's hierarchy, we know that it's very hard to work on higher order things unless the basics are cared for. We have a basic need for food, clothing, and shelter. They're the essentials. Beyond that, we want to experience safety, freedom from violence. We also are social creatures, and so we need to feel like we belong. So those social and community connections, which get started in our families of origin, are so important. That helps us build a sense of cooperation, self-efficacy, which then lets us go beyond our family and participate in the life in the community. So the confident young person who has a strong family upbringing, is armed well to come out and participate in the larger context of society. Now, the ACEs study was pretty sobering when it came out. The original ACEs are listed there in red. And what this looked at was a number of adults who were actually experiencing difficulties in their lives. And so when they went back and actually inquired about some of their experiences before age 6, they found that a substantial number of them had suffered some traumatic loss, bereavement, or separation, or had been victims of violence in the home, had lived with an impaired caregiver, perhaps someone with chronic mental illness, had suffered emotional abuse or neglect. Some even suffered physical abuse or sexual abuse. The other ones that are farther down the line there have been validated in subsequent studies that show that experiences such as community violence, sexual assault or rape, a serious injury or accident, or witnessing school violence can also have a major impact. So when you look at adults who have had a number of these traumatic experiences and subsequent risks for behaviors in their adult life, the association is very strong. Here's a cartoon that shows the number of ACEs, or adverse childhood experiences, relative to the future of intravenous substance abuse. And you can see a dramatic progression there, that particularly with 4 or more adverse childhood experiences, there was a statistically and clinically significant increased risk for intravenous substance abuse. The same holds for adult alcoholism. Again, you can see a dramatic progression from 1 adverse childhood experience to 4 or more. Among adverse childhood experiences and future history of the likelihood of more than 50 sexual partners, you can see here that while not quite so exponentially dramatic, there is an increase over time. If you think about the child's experience, having something traumatic happen at a very young age frequently destroys the trust that they would want to have implicitly in the relationships that are part of their early lives. Perhaps this statistic may represent their desire to create that type of trusting relationship, looking for love. I'm going to get out of there, and we're going to go to the next slide. The readiness for change model, developed by Prochaska and Di Clemente, describes 5 stages of getting ready to make a change. Think of the last time that you needed to make a change in your life. Maybe you wanted to become more fit, or you wanted to get better grades in your exams. You had to really sit down and think about where your starting point was. And you had to kind of weigh out whether or not it was going to be worth the extra work it was going to take. So we see these 5 stages. The pre-contemplative stage is kind of that ignorance is bliss. But sooner or later, you start to thinking about, okay, I really got to quit smoking. I really got to lose some weight. So if I'm going to do that, what am I going to have to give up? Certainly, there are some cons to making the change, but we would hope that the pros of doing so would outweigh the cons. On the other hand, there are some pros to not making that change. And we know, particularly with something like smoking or some other health behavior that would be troublesome for long-term health, not making a change has a downside. Once a person has thought through what they want to do, they have to get ready. They have to get motivated. They may seek advice. They may go see a nutritionist. They may read up on the internet. They've got to get a game plan together. And then once they've done so, they're ready for action. And that process can actually last for quite a period of time. And it's not without its pitfalls, because in some cases, there may be some factor that intrudes and kind of throws them back and destroys their game plan. On the other hand, a person who has taken action and continues to practice their new behavior can actually achieve a new plateau and can actually enter a maintenance phase. We understand that all of us do this. We kind of have periods of success, and then we have times when something may come along and knock us off our horse, and we have to start over. It's not unlike being forgiven and then having to avoid those patterns of sin that we sometimes can get into. Victor Montori and his colleagues developed something called the workload capacity model to help describe patients who had chronic medical conditions and how they need to approach their work and what tends to keep them in balance with better health, and what can sometimes, when they become out of balance, result in illness or feeling stuck. So if you think of the work of a patient on the right-hand side of this cartoon, they have to do an awful lot. Let's say you've been diagnosed with diabetes. You don't really know anything about this condition, but now you have to gather lots of information. You have a doctor or a nurse practitioner or a PA who's helping to give you advice, setting some goals on how to maintain good glycemic control. There's a whole vocabulary. You've got to go to appointments. You may be taking medications that are new. So you've got a certain task list, and there's also some monitoring that's required. This takes time, and it has to be integrated with all the other things you have going on in your life. Oh, and by the way, we want you to eat healthier and lose weight. So many of these can become rather stressful for patients, and their capacity to participate in this change may depend on, do they have adequate support? Do they have financial resources? Some of the medications for diabetes are quite expensive. If they're employed, it makes paying the bills easier, but some of our patients are actually faced at the end of the month with having to make choices between paying the rent and paying for their medications. Personality plays a part. Some people are go-getters. Some people can be put back on their heels pretty quickly. If a person is feeling low, if they feel depressed, or perhaps they're fighting an acute illness, they have less capacity to put up the effort that's needed to take care of themselves. And finally, cognitive impairment. So for elders who may be losing some of their skills for coping, this makes them very, very vulnerable for not being able to do the work of a patient. So you can see how these sort of play out in a balance, and that our illness, we never take care of our illness in a vacuum. These are really important things for us to know as we encounter our patients. And I want you to think of Lydia now in terms of, what are the questions you would want to know more about her and what her life experience has been? What have been some of those adverse childhood experiences that may have destroyed trust or made her more likely to take risks? From a standpoint of managing symptoms, what are some of the drivers of the symptoms that patients may have when they come in? What's their current context? What's their current workload? Are they caring for children? Are they working full-time? Are they working overtime? Are they sleeping adequately? And so the more we learn about patients, the more we can understand their world, and we can help create a safe environment for them, get them to trust us by building our own relationship and sense of connectedness. But now we can function not just with the physiological advice that we can give, but we can help be Christ to them by supporting them, loving them, and helping to teach them coping skills and emotional regulation. From a spiritual standpoint, I've really found the corporal and spiritual works of mercy to be a great foundation for me as I try to be present to the patients that I care for. Sometimes it's the basics of listening, helping them to get connected to social services or to other sources of support. Sometimes it's calling them back at the end of a long day because they've called or sent a message just a couple of days after their last visit because they forgot to ask something. In other cases, they have wounds in their own lives, and they're very ambivalent as to whether they can find the way forward to forgive others who have harmed them. They may have doubts about their ability to carry forth and to essentially live their lives and feel supported. And they may be working environments that can be where they may feel persecuted, where they may have relationships that are broken, and bearing through them and praying through them. I also have found that simply offering a comforting touch with a hand to comfort the patient. If you've discovered that they have a spiritual side, you can ask them if they belong to a community of faith and if they find that helpful. In those settings, I've even asked patients if they would like to pray toward the end of an encounter. I never do this without first checking with the patient as to whether this is a part of who they are, if they have a strong spiritual limb or not. But assuming that they do, I have been encouraged by the number of my patients who have a very strong and deep faith, and that becomes an important part of their healing as well. So I hope that you've enjoyed this little overview, and I hope it'll help you be more effective in the relationships that you have with the patients that you care for. I look forward to speaking and connecting with you again.